Hey, welcome to your renal posting. In this explainer, we're going to break down Chapter 6 of the Ktph Renal Survival Guide, all about hypertension. We'll take a super practical, case-based approach to walk you through managing one of the most common issues you'll see on the wards, all based on our local guidelines.
Okay, so you get that call. Your patient's blood pressure is 185/115. That's a number that gets your attention, right? But hold on. Before you even start thinking about what drug to give, what are your immediate goals? We're going to use this exact scenario to guide us through the whole process, step by step.
All right, let's start at the very beginning, the initial encounter. Before you do anything else, your number one job is to make sure you're dealing with the real problem. Is that 185/115 actually a true reflection of what's going on?
Think of this as your mental checklist, your game plan for every single patient with a high BP reading. Number 1, confirm it's real. Number 2, put on your detective hat. Look for underlying causes and any damage that's already been done. 3, you gotta decide how fast you need to act. And finally, number 4, start treatment in a way that helps, not harms. This framework will keep you and your patient safe.
It sounds so basic, but these simple steps are absolutely critical. A cuff that's too small can give you a falsely high reading. If the patient just ran to the clinic, that can do it too. And always check both arms at least once. A big difference there could be your very first clue that something else is going on, maybe with their blood vessels. Getting this right is the foundation for everything else.
Okay, so you've confirmed the number is legit. Now what? Now it's time to build the clinical picture. This isn't just about a number, it's about a person. We'll start with a good history, a focused exam, and a few key baseline tests to really figure out what's happening.
When you're taking a history, you need to be targeted. Ask about things that could be pushing the BP up. Are they taking NSAIDs for knee pain or steroids for something else? Do they snore like a freight train and feel exhausted all day? Maybe obstructive sleep apnea. And are they getting chest pain or swollen ankles? That tells you the high BP might already be causing some serious problems. Every question has a purpose.
So this is pretty much your standard workup for a new patient with hypertension. And you can see exactly why we're ordering each test. We're not just ticking boxes. We're checking the kidneys with a renal panel, or screening for diabetes with an HbA1c, and we're looking at the heart for any signs of strain with an ECG. It gives us a really comprehensive first look. All right, so we've confirmed the diagnosis, we've gathered our data, now it's time for the action plan. For our patient with that BP of 185/115, what exactly are we aiming for, and what tools are we going to use to get there?
Now this is super important. Not every patient has the same target. For most people, getting them under 140/90 is the goal. But here in the renal world, for patients who have a lot of protein in their urine, or especially if they have a kidney transplant, we have to be way more aggressive. We're aiming for 130/80 or even lower, all to give that kidney the best possible protection. Okay, let's talk about something that freaks a lot of junior doctors out. You've started treatment, maybe an ACE inhibitor, you recheck the labs a week later and the creatinine has gone up. Is this a disaster? When do you worry and when do you just, chill out? I want you to burn this sentence into your brain. This is one of the most important clinical pearls in this entire chapter. When you start an ACE inhibitor or an ARB, it's very common and in fact it's expected to see a little bump in the creatinine. A rise of up to 30% from their baseline is generally okay. So please, don't panic and stop a life-saving medication too early.
So when should you start worrying about something more serious, like renal artery stenosis? Well, you really only pull that trigger in these specific high-risk situations. If the kidney function just keeps getting worse and worse, or if you just cannot get their blood pressure under control with 4 or more drugs, or if they have these episodes of sudden, severe shortness of breath, then it's time to start investigating. Otherwise, you're probably just chasing shadows.
Okay, let's ratchet up the intensity. Our patient with the 185/115 BP now develops a crushing headache and blurred vision. The whole situation just changed. We've officially moved from routine management into a true medical emergency. This slide, this distinction is everything. Urgency versus emergency. Look, the blood pressure number itself can be identical. The one and only thing that matters is this. Is there evidence of acute, ongoing organ damage? If there's no damage, you've got a bit of time, you can use oral meds. But if there is damage, like they're confused, having a heart attack or a stroke, that patient needs to be admitted for IV therapy right now. In the whole universe of hypertensive emergencies, this is the big one, the one you absolutely cannot afford to miss.
Aortic dissection. Here, the goal is to reduce what we call shear stress on the wall of the aorta, and that means you must control the heart rate first with a beta blocker before you lower the blood pressure. If you get that sequence wrong, it can be catastrophic. Remember, rate first, then pressure.
And here's another tricky one you have to know about: scleroderma renal crisis. The patient comes in with crazy high blood pressure and their creatinine is just shooting up. Your first instinct, your brain, is probably screaming at you, "Don't give an ACE inhibitor, it'll make the kidneys worse." Well, in this very specific disease, your instinct is wrong. An ACE inhibitor is the life-saving treatment, and you have to start it immediately, no matter what the creatinine is doing.
So, you've decided you need IV meds. Which one do you grab? Here's a quick cheat sheet. If the emergency is heart-related, like a heart attack or flash pulmonary edema, GTN is a fantastic choice. For just general-purpose control, or in a stroke, labetalol is your go-to workhorse. And for that critical aortic dissection where you need really tight, fast control of the heart rate, the super short-acting esmolol is perfect.
Phew! Okay, we have gone all the way from a routine high reading to a full-blown, life-threatening emergency. So let's distill all of that down. What are the absolute key principles you need to walk away with for your next shift?
Honestly, if you forget everything else, just remember these 4 points. 1. Garbage in, garbage out. Make sure the BP reading is actually accurate. 2. Don't be scared of that small expected creatinine bump after you start an ACE inhibitor or an ARB. 3. Organ damage. The presence or absence of it changes absolutely everything. And 4. For aortic dissection, think rate before pressure. These 4 principles will keep you on the right track.
And there you have it. That's your practical guide to hypertension management, straight from the Renal Survival Guide. Keep these ideas handy, always be systematic, and never ever hesitate to ask for help. We wish you the best of luck with your posting.